John again over in the pharmacy.
Okay, it worked.
Great.
Sorry.
Oh, that's fine. This is John again over in the pharmacy. Just wanted to go over a couple of other things with you guys as far as your NCLEX reviews. So it's going to be a little bit different than last time because I'm flying solo today. Yeah, we're going to go ahead and go through some things, and I'm hoping that this will be beneficial for all of you. Again, if you have specific questions, you can always email me. I'm available. It's not a big deal. I'm happy to help you guys. Like I said on the last recording, we all have a great interest in all of you doing well and all of you doing what you need to do so that we can get you on board. We absolutely need the help. We absolutely need the help, okay? So let's get started here. The first question I have is: a topical corticosteroid is prescribed by a healthcare provider for a child with contact dermatitis. Which instructions should the nurse give the parent about applying the cream? Number one, apply the cream over the entire body. No. Number two, apply a thick layer of cream to affected areas only. No. Number three, avoid cleansing the area before application of the cream. Again, no. Number four, apply a thin layer of cream and rub it into the area thoroughly. Number four is the answer, okay? Obviously, you would want to instruct them to cleanse the area before application, okay? Again, we don't typically apply a thick layer to affected areas, okay? And we also do not sit here and apply the cream over the entire body. That would be pretty ridiculous. So again, topical corticosteroids, eczema, thin layer, rub it into the area thoroughly, okay? I think that's fairly I think that's fairly straightforward. I apologize, these questions are a little bit all over the place, and I'm gonna go ahead and just go through them as they come to me. My next question is number 308. The nurse is instructing the parents of a child with iron deficiency anemia regarding the administration of a liquid oral iron supplement. What instructions should the nurse tell the parents? Administer the iron at mealtimes. Administer the iron through a straw. Mix the iron with cereal. Add the iron to formula for easy administration. The answer that they're looking for here is answer number 2, okay? So again, that would be administer the iron through a straw. So again, oral iron supplements should be administered through a straw or a medicine dropper placed in the back of the mouth because the iron stains the teeth, okay? So again, you want to make sure we're doing everything we can for the patient, and the iron can stain the teeth, so you're going to want to give it through a straw, okay? Let's see, my next question is coming up here. Number 312 I have, okay? This is the NCLEX RN examination 8th edition. So I'm looking at number 312 is the question, okay? A nurse is monitoring a child for bleeding after surgery for removal of a brain tumor. Oh my gosh, that's sad. A nurse checks the head dressing for the presence of blood and notes a colorless drainage on the back of the dressing. Which action should she perform immediately? Notify the surgeon. Reinforce the dressing. Document the findings and continue to monitor. Circle the area of drainage and continue to monitor. So again, the answer is number 1. A colorless drainage on the dressing after the craniotomy indicates the presence of cerebral spinal fluid and should be reported to the surgeon, okay? So again, you want to make sure you understand that the cerebral spinal fluid, if it's not sealed off, could possibly cause an infection, correct? Also, if we don't have enough cerebral spinal fluid, the patient's going to get a terrific headache, okay? So again, these are the things the surgeon needs to know. They may need to come by and reassess, okay? Okay, great. My next question here is number 323 and 325. 323. A school-aged child with type 1 diabetes has soccer practice and the school nurse provides instructions regarding how to prevent hypoglycemia during practice. What should the school nurse tell the child to do? Eat twice the amount normally eaten at lunchtime. Take half the amount of prescribed insulin on practice days. Take the prescribed insulin at noontime rather than in the morning. Eat a small box of raisins or drink a cup of orange juice before soccer practice. So again, type 1 diabetes, we're all aware, this is not the patient that gets the metformin. This is a patient that is completely insulin reliant. And because of that, when they're doing sports, we want to make sure that they have some extra carbohydrate in their body, which would be the box of raisins or orange juice before practice. That provides them with the immediate glucose that they need, that they will then burn through during the practice. Okay, does that make sense? So basically, you kind of have to look at this from the standpoint of the disease process and what we need to do to rectify that so the patient doesn't have a problem. And again, as I'm looking at the answer, it is number 4. And again, a small cup of raisins or orange juice is 15 to 30 carbs. The child and parents should be instructed to adjust the amount and the time. It should not be instructed to adjust the amount or the insulin. Meal amounts should not be doubled. So again, same amount of insulin, same amount of meals, but we're going to add in a little snack so they don't have a problem during practice. My next one is 325. A pediatrician prescribes an intravenous solution of 5% dextrose with half normal saline, 0.45, with 40 MEQs of potassium chloride for a child with hypotonic dehydration. The nurse performs which priority assessment before administering the IV prescription? Weight, temperature, blood pressure, checks the amount of urine output. So, temperature would be more indicative of a situation like infection, okay? Blood pressure could also be indicative of infection. We're all aware that the infectious process can affect blood pressure. It can be a sepsis marker. So, again, probably not those two, right? As far as the weight is concerned, none of those medications are weight-based. So that would be incorrect. But again, we would want to check for the urine output, okay? And that's important because we need to make sure that the patient can urinate because they need to be able to get rid of potassium chloride. The potassium will stay in their system if they cannot urinate, and as the potassium climbs, it can become very dangerous for the patient. In hypertonic dehydration, electrolyte loss exceeds water loss. The priority assessment before administering potassium chloride IV would be to assess the status of the urine output. KCl should never be administered in the presence of oliguria or anuria. If the urine output is less than 1 to 2 mils per kg per hour, potassium chloride should not be administered, okay? So that's basically what is going on in that scenario. Sorry here, just getting to my next question. Okay, I have 338. A nurse admits a child to the hospital with diagnosis of pyloric stenosis. On assessment, which data would the nurse expect to obtain when asking the patient about the child's symptoms? So again, what's going on? Pyloric stenosis. Let's think about this for a second, okay? Would they have watery diarrhea? Would they have projectile vomiting? Would they have increased urine output? Or would they have vomiting large amounts of bile? So again, what is the disease process that we're looking at here is the big question, okay? In pyloric stenosis, hypertrophy of the circular muscles of the pylorus causes a narrowing of the pyloric canal between the stomach and the duodenum. Clinical manifestations of the stenosis include projectile vomiting, okay? So again, your esophagus essentially is affected and the pyloric sphincter has become larger, so it does not allow the food to pass, so you have a bunch of projectile vomiting, okay? So that is what's going on in that scenario. So again, it's more of a understanding the disease process question, okay? My next one is 340. A nurse is preparing to care for a child with a diagnosis of, interoception. The nurse reviews the child's record and expects to know which sign of the disorder documented. I'm not going to lie to you guys. I don't know the answer to this one, so we're going to go ahead and take a look at it, okay? Let's see, 340. Interoception is a telescoping of one portion of the bowel into another. Ooh, that doesn't sound good. The condition results in an obstruction to the passage of intestinal contents. A child with interoception typically has severe abdominal pain that is crampy and intermittent, causing the child to draw its knees to the chest. Vomiting may be present, but is not projectile. Bright red blood and mucus are passed through the rectum and commonly described as current jelly-like stools. Watery diarrhea and ribbon-like stools are not manifestations of this disorder. So again, because you have a telescoping of one part of the bowel to another, it causes bleeding and causes redness in the stool, and that's what's going on in this situation. Look at that, I didn't know that one. I learned something today. Okay, our next one here, 343. A mother of a 6-year-old child arrives at a clinic because the child is experiencing itchy, red, and swollen eyes. The nurse notes a discharge from the eyes and sends a culture to the laboratory for analysis. Chlamydial conjunctivitis is diagnosed. On the basis of this diagnosis, the nurse determines that which requires further investigation. So again, are we looking at trauma, sexual abuse, allergies, or respiratory infections? So let's think about this for a second. I think we all know that chlamydia is a sexually transmitted disorder. So unfortunately, this situation would call for a sexual abuse investigation, which is exceptionally sad. I'm just going to read what they have written here. Diagnosis of chlamydial conjunctivitis in a child who is not sexually active should be assigned to the healthcare provider to assess the child for possible sexual abuse. That again is that's what would happen in this scenario. Okay, 344. The nurse prepares a teaching plan for the mother of a child diagnosed with bacterial conjunctivitis, which, if stated by the mother, indicates a need for further teaching. Okay, here we go. I need to wash my hands frequently. Nope. With bacterial conjunctivitis, you absolutely do. I need to clean the eyes as prescribed. Again, that is also accurate. It is okay to share towels and washcloths. Again, that's one of the ones that is a possibility, okay? I need to give the eye drops as prescribed. So again, we do need to give the eye drops as prescribed. So I believe the answer here is 3. Let's take a look. Yes, it is 3. So again, bacterial conjunctivitis is extremely able to be transmitted when you're using the towels. So when you talk to the mom, you need to make sure, yes, you wash your hands. Yes, you clean the eyes as indicated. Yes, you give the eye drops as prescribed, but also do not share the towels. That's going to lead to infection of mom, dad, the other kids, the grandparents, whoever, okay? So that would be the one that's an indicator for further teaching. Let's take a look at 347. After a tonsillectomy, the nurse reviews the surgeon's post-operative prescriptions. Which prescriptions should the nurse be questioning? Monitor for bleeding. Nope, absolutely monitoring for bleeding. Suction every 2 hours. Possibly. Give no milk or milk products. Give clear, cool liquids when alert and awake. So the answer here is which one we'll be questioning is number 2, which was the suctioning every 2 hours. Reason being, again, what is a tonsillectomy? We're looking back at what happened to this patient. It's a removal of the tonsils. After a tonsillectomy, suction equipment should be available, but suctioning is not performed unless there is an airway obstruction because of the risk of trauma to the surgical site, okay? So again, if we're going to be suctioning every 2 hours on a fresh surgical site, that could also cause an issue, okay? And I think that makes sense. All righty. My next question here. Sorry, just navigating. Give me a second. Next question is 352, okay? Here we go. 10-year-old with asthma treated with acute exacerbation in the emergency department. The nurse caring for the child should monitor for which sign, knowing that it indicates a worsening of the condition. Warm, dry skin. Probably not. Decreased wheezing. So again, we're talking about a worsening of the condition. If the wheezing goes down, I don't believe that's going to be the problem. Let's take a look here, though, because the answer is written down. It says 2. Okay, here we go. The decreased wheezing is the answer. And again, I learned something today as well. So again, the asthmatic or the chronic inflammatory airway disease, the decrease in wheezing in a child with asthma may be interpreted incorrectly as a positive sign when it may actually signal an inability to move air. A silent chest is an ominous sign during an asthma episode. With treatment, increased wheezing can actually signal the child's condition is improving. Warm, dry skin indicates an impairment in the child's condition because the child is normally diaphoretic during an exacerbation. The normal pulse rate in a 10-year-old is 70 to 110. The normal respiratory rate in 10 to 16 is 20 beats per minute. So again, what we're looking at here is the silent chest means we can't move the air, and that's what they were talking about with that question. I feel as though that question was a little bit misleading, but again, they could certainly ask that on the boards, and you're certainly going to want to be aware that the silent chest is the big issue in this situation. Our next one is 359. The mother of a hospitalized 2-year-old child with viral laryngeal bronchitis, croup, asks the nurse why the pediatrician did not prescribe antibiotics. Which response should the nurse take? The child may be allergic. The child is too young to receive antibiotics. Antibiotics are not indicated unless a bacterial infection is present, or the child still has maternal antibodies from birth and does not need antibiotics. So again, number 4 is absolutely not correct. It's a 2-year-old, so those maternal antibodies are completely gone. As far as the allergy, if the patient had an infection that was bacterial in nature, you would absolutely give antibiotics. You would not be saying to yourself, there's an off chance they're allergic. That's a little bit ridiculous. The child is too young to receive antibiotics. That's completely inaccurate. I've given antibiotics to kids that are 6 hours old, probably even less than that. So again, our answer is antibiotics are not indicated unless a bacterial infection is present. So again, you're going to have patients asking this question, parents asking this question, and it's always, we got to get back to being vigilant with our usage of antibiotics. We can't just throw antibiotics at everybody. That's what they want, but that's not what they're always going to get, okay? And you want to make sure that they understand that. Okay, here. My next question is 366. A nurse is closely monitoring the intake and output of an infant with heart failure who is receiving diuretic therapy. The nurse should use which most appropriate method to assess urine output? Weighing the diapers, inserting a urinary catheter, comparing intake and output, measuring the amount of water added to the formula. So basically, in this situation, your most accurate assessment is going to be weighing the diapers, okay? So again, what we're looking at here is what is our basic understanding of the situation. Again, heart failure is the inability to perfuse the body correctly. So in this case, we put them on diuretics in order to control their symptoms. And when they're on diuretics, they can lose a lot of water weight. So we will be monitoring it. What's the best way? We weigh the diapers, okay? Okay, here we go. 370. A pediatrician has prescribed oxygen as needed for an infant with heart failure. In which situation should the nurse administer the oxygen to the infant? During sleep? Well, probably not. When changing the diapers? Probably not. When the mother is holding the infant? Again, that should be a relaxing time. They shouldn't necessarily be needing oxygen at that point. Again, we will be looking at, in this situation, number 4, which is when drawing the blood for electrolyte blood testing, okay? And the idea is, the heart cannot perfuse the body. Crying exhausts the infant. So again, as we're drawing these labs, they're going to start crying, right? Which we don't want, but unfortunately, that's the case. It will exhaust their already limited ability to basically be able to compensate. And because of this, we're going to prophylactically treat them with oxygen so that we can kind of bump up those levels and prevent them from having an issue. Okay, my next question. Number 376, 377. Okay, 376. A nurse provided discharge instructions to the patient of a 2-year-old child with the ophrexy to correct cryptotortism. Which statement by the parents indicates the need for further instruction? So again, it's another need for further instruction question, okay? And because of this, we're going to have to understand the disease state. So this cricocordiism is a condition in which one or both of the testicles fail to descend through the inguinal canal into the scrotal sac. Surgical correction may be necessary. All vigorous activity should be restricted for 2 weeks after surgery to promote healing and prevent injury. So here we go. I'll check his temperature. Again, we want to doing that because the patient's had surgery and they could possibly have an infection, especially in the groin area. Very easy to get an infection there. I'll give him medication so he'll be comfortable. Again, we want to be doing that. We want to get ahead of the pain. I don't need to tell you that. I'll check his voiding to be sure there's no problem. Again, having surgery there, if something were to have gone wrong, he wouldn't be able to avoid correctly. I'll let him decide when to return to his play activities. That's the incorrect one here, okay? Because again, he needs to have time to heal adequately. And it's not up to him to decide when, it's up to the medical professionals to decide when. Number 377, the nurse is reviewing a treatment plan with the patients of a newborn with hydrocephalus. Which statement by the parents indicates their understanding of the plan? Again, let's go ahead and take a look at what this is. The hydrocephalus is a congenital defect involving abnormal placement of the urethral orifice of the penis. In hydrocephalus, the urethral orifice is located below the glans penis along the ventral surface. The infant should not be circumcised because the dorsal foreskin tissue will be used for surgical repair of the hydrocephalus. So, let's take a look at what the people are saying. Caution should be used when straddling my infant on a hip. Vital signs should be taken daily to check for bladder infection. Catheters will be necessary when my infant does not void. Circumcision has been delayed to save tissue for surgical repair. Okay, so like I just said, we don't circumcise these kids because, again, we have to use some of that foreskin in order to correct the issue that this young man is having. So 1, 2, and 3 are fine, but number 4 indicates they understand the plan the best. Okay, moving on to our next question. All right, 383. Nurse notes documenting that a child is exhibiting an inability to flex the leg when the thigh is flexed anteriorly at the hip. What condition does the nurse suspect? Let's see. In this one, we're looking at possibly meningitis. It's an infectious process of the CNS caused by bacterial or viruses. The inability to extend the leg at the thigh, at the hip, when flexed anteriorly at the hip is a positive Karen sign noted for meningitis. Karen sign is not seen specifically with spinal cord injury, intracranial bleeding, or decreased cerebral blood flow. So again, this Karen sign, that's what we're looking at for meningitis. 292, a nurse is creating a plan for a child who is at risk of seizures. Which interventions apply if the child has a seizure? Select all that apply. Time the seizure, restrain the child, stay with the child, place the child in a prone position, move furniture away from the child, insert a padded tongue blade in the child's mouth. Okay, so we need to figure out exactly which ones we need to do. So again, we want to time the seizure. That's going to be important. For the neurologist, was it 3 minutes? Was it 12 seconds? That makes a difference. Obviously, we want to stay with the child. You don't just leave. They could obviously hurt themselves pretty badly. I mean, what if they're on a ladder? What if they're, playing at the park, they're up the slide and they fall off the top? I mean, there's a whole lot of things that can go wrong very quickly in this situation. Again, the 5th one, move furniture away from the child. I don't think I need to say that, but obviously if you're seizing, we don't want you falling over and smacking your head on the table or a chair or something else that could potentially cause issue. Okay. Take a look here. So the next section here is going to be the integumentary system. So again, there's not a ton here. Basically, there's steroids for, the allergic reactions and things like that. There's also topical antibiotics and topical antifungals, which are utilized. There's not a whole lot as far as from a drug therapy standpoint. I don't have any other questions marked, so I'm just kind of going off the cuff here. I apologize. If you give me a second, I can take a look at some of these. Let's see. Yeah, I'm going to move on here. Our next one is going to be oncology medications. So, you know, I have a hard time thinking that they would be asking you for, a hard time believing they would be asking you for anything as far as looking at, you know, which treatments would be acceptable. Basically, with the oncology medications, some of them have different parameters attached to them, but, you know, your big ones are going to be like ANC. Okay, that's a big one. Making sure their blood counts are good enough to get the chemo, because again, we know that the chemotherapy can decrease those counts, and we don't want to have them so low that the patient's at risk of infection or bleeding. That's a big one. Also platelets, they can affect the platelets. So that's another thing to be concerned about. We want to make sure that the platelets are sufficiently high, because they can of course be toxic to the platelets as well. Additionally, some of them can mess with the electrolytes. Okay, so we want to make sure that the lights are good. Sometimes they'll require supplementing magnesium or potassium or something like that. That happens, you know, fairly often. You know, patients can also have issues with nausea and vomiting, fatigue, things like that. And when that happens, they usually talk to the doctor, and we'll be making changes. You know, again, I hate to say it like this, but chemotherapy is very dangerous if not done correctly. It can definitely cause patients issues. So again, we work very closely with the physicians and the nurses to see how the patients are doing, to make the adjustments that need to be made in order to optimize the outcomes. So yeah, basically, all I can really see them asking will be questions like that. You know, there are meds out there that have blood pressure parameters. There are meds out there that have you know, other parameters attached to them, such as renal function, and you would then like reduce the dose in the event that there was a problem. Also, there are situations that come up with the liver, because, you know, obviously the liver is the filter of the body, and if it's filtering out what essentially amounts to poison, it can be affected, and that's where you're going to have these alterations in the ALT, AST, alterations in the total bilirubin. So we keep an eye on these things for the patients. The other things we see is like peripheral neuropathy. That's another big one to look out for. And that leads to a lot of medications either being DC'd or dose reduced, or the patient fails and they have to pick it up the next week or the next cycle, maybe in 3 weeks. Those will be the things that come up with the chemotherapy. Okay, let's move on to the next thing. Oh, wonderful, endocrine. I'm going to share a little secret with you guys. I barely passed my endocrine module in pharmacy school. Gotten a lot better at it, though, let me tell you. Gotten a lot better at it. So yeah, let's talk a little bit about some endocrine disorders. You know, your primary one you're going to see all the time is going to be diabetes. Okay, that's the big one, right? And what do we know about diabetes? We talked a little bit about the type 1 with that patient before. Type 1 is completely insulin dependent. Okay, they require insulin every single day. That's just what they have to do. But your more prevalent one would be your type 2s. Okay, so they may or may not require insulin. Some of them can be managed on orals. So this type 2 diabetic requires several different medications. They basically need to have metformin in the event that they don't have kidney problems. They typically are put on an ACE inhibitor because this will help their kidneys to be protected. In addition, they're typically put on a statin and aspirin. Again, these are cardio and stroke protective in this population. The type 2 diabetic is at much greater risk of having an issue with a heart attack or a stroke. So the statin and the aspirin help to protect them from these things. So yeah, let's talk a little bit about some insulins here, okay? So your short duration rapid onsets are going to be Lispro, Aspart, okay? It says insulin glycine here. I mean, whatever. That's not one that I've ever actually seen professionally. So the Aspart and the Lispro, we actually have Lispro, I believe it's Lispro here at the hospital. So again, shorter duration, slower onset would be regular insulin. That's what we use in our insulin drips here, okay? And then we have intermediate acting, which is NPH. Again, we don't carry that anymore. That's really fallen out of favor. Your long acting would be like Glargine and Detamir. We have Glargine, we used to have Detamir. So yeah, we utilize the Glargine. It's really kind of amazing. I wish you could see me, but the curve of the activity for the Glargine is really incredible. It almost completely mimics your body's own insulin production. And it's really, I mean, it's a fantastic piece of medical technology. I've always been impressed by the Glargine. Now, the Detamir actually does have a peak and a trough to it, but basically we've shown in studies that that's essentially insignificant. So, either one is okay to use for your patients. So, just if you have a diabetic patient and they're asking you about insulins, you're going to want to refer to this chart. This is your short acting. This is what we would use, postprandial, something like that. Long acting, we can give whenever, typically at bedtime. That's when I take mine. And we would give that at the same time every day in order to mimic their own body's production of insulin. And yeah, I think that pretty much covers. I mean, they might ask you some questions about hypo and hyperthyroidism. That's a subset of the population that is not nearly as prevalent as the diabetic. So that's why I covered the diabetes stuff. Okay, let's keep going here. Okay, we have some GI meds. Let's take a look at this. Just gonna open the door here. Excuse me. Okay, gastrointestinal meds. Let's see what we got. So let's talk a little bit about antacids. So again, antacids will be used for, a patient has sour stomach, they feel as though their acid production is too high, calcium carbonate Tums, there's your standby. It's, I think, dosed every 4 to 6 hours, something like that. Pretty easy to remember stuff. Your H2 blockers will be something like Pepcid, okay? Again, utilized for the same reason, but you dose it less frequently, It's dosed twice a day, typically 20 milligrams, twice a day. Let's see. So there are other medications out there. Prokinetics would be like metoclopramide. So again, it stimulates the upper GI tract to increase the rate of gastric emptying without stimulating the rest of the GI tract. Again, that can be utilized in diabetics. Also, it can be utilized post-surgery in order to get somebody's guts to wake up. Again, we also have stuff for treating hepatic encephalopathy. The medication of choice would be lactulose. And again, we would give that, I believe we can give it up to Q6. It's pretty much titrated to diarrhea because, again, we're trying to get that ammonia out. There's some treatments for IBS and Crohn's. I can't really see them asking questions about that. That's a pretty small subset of the population. But we can talk about antiemetics. Again, control nausea and vomiting. Your big one is going to be Zofran. That's your workhorse agent, okay? Zofran, we give it all the time here. I'm sure I've verified thousands of Zofran orders over the course of my career. We also give it over at the cancer center in a bit of a higher dose because, again, these patients are taking medications that are known to cause nausea and vomiting, and we want to make sure that they're covered for that. So your standard would be 4 milligrams IV push every 4 hours as needed. At the cancer center, we give 12 milligrams in a bag over 15 minutes. The other one that we give over at the cancer center would be Amend, but that's only indicated for chemotherapy-induced nausea and vomiting. So again, you wouldn't be giving that in the surgical suite or anything like that. As far as some other medications, you know, we can give things like Haldol, okay, that's certainly been used. Trimethylbenzamide or Tygan, that's another one that we can use. Again, we can also use steroids, okay, the steroids also can help. So, you know, a patient that's on a highly hematogenic regimen may be on, you know, Amend, Zofran, and steroids, and also possibly Haldol, okay? So again, we will maximize the patient in any way that we can to prevent the nausea and vomiting. Another option would be like transdermal scopolamine. Again, that's pretty much off the beaten path. That's more for your patient that's end of life. And then Ativan can also be used. Sometimes they anticipate this and it can be an issue. And as they anticipate it, we can give Ativan and help them to correct that. Also, I've seen Benadryl used. Sometimes patients have too much acid production and the Benadryl is used to cut down on that production. And that way they can then hopefully be okay and not need it. Let's talk a little bit about laxatives, okay? You know, you're going to be giving a lot of these in your career, I can promise you. You know, your big ones are going to be things like, you know, Miralax, polyethylene glycol. Again, that's one of the safest medications in the entire world. My daughter's been on it. She's 2 years old. So that's, you know, very, very safe. You know, Bisacodyl and Senna and Docusate, those are your other ones. So, you know, again, your typical situation would be, you know, your patient has had surgery, let's say on their knee, and we're trying to get their guts to wake back up, okay? So what we would do is we would give things that are stimulants, something like Senna, something like Bisacodyl, also possibly the Docusate. And, you know, we would wait for them to, you know, have the bowel movement before we let them go. That's usually pretty critical. And after they have that, they can usually be discharged. So, okay. Okay, let's talk a little bit about respiratory problems. So again, we talked a little bit about, I talked a little bit earlier about COVID pneumonia on a different talk. I apologize. We will cover a little bit more about pneumonia right here, okay? So, you know, your patient is admitted with pneumonia. Let's say it's community-acquired pneumonia. We would give antibiotics in the form of Rocephin and Zithromax. And we would also have other situations where we would give, if they were allergic, say, to beta-lactams or penicillins, we would give them Levaquin typically in that scenario. Additionally, because they're having difficulty breathing, we're most likely going to be giving them albuterol, possibly something to control their secretions, something like the guaifenesin. Additionally, we would most likely not be giving fluids unless necessary because fluids have already deposited in the lungs, and if you give fluids, they will just redeposit there and kind of defeat what you're trying to get done as far as clearing the lungs out. Also, I talked earlier about the use of steroids. Steroids help your patients, your patients that have this issue. They help to open up the lungs. They help to decrease secretions. They help the patient to just feel better in general. And that being the case, steroids are utilized pretty heavily in this population. So will be some monitoring parameters for, pneumonia, right? The first thing would be like O2 requirements. So if they are not on O2 at home and suddenly they need it, that's not a good sign. So we want to make sure we wean them down to nothing again. So that'll be a big one. Also, obviously, during an infectious process, we can monitor temperature. That's important. We can also monitor the white count. That's important. But the white count, if they're on steroids, can become unreliable because the steroids can increase the white count. Also, you guys are with the patient the entire day. Just ask them how they're feeling. Do you feel better? Do you feel worse? That's very important because if they're feeling better, we can typically discharge them. So just some stuff to be aware of. So let's talk a little bit about asthma. I'm sure you all know what that is. Basically, a lot of times it's induced with exercise. The bronchioles will close up and you don't have sufficient air exchange. Your standard treatment would be albuterol. That would help to open up the airway and help to make the patient feel better. Also, we could use something like ipratropium to help to dry up secretions. Additionally, the usage of steroids is also indicated in the short term for an acute exacerbation. And a lot of times they may have a positive chest x-ray, and if they do, we typically see doxycycline in that situation. Okay. So some respiratory medications, we already talked about those, our albuterol, things like that. Again, our anticholinergic, we talked about those, ipratropium. We talked about the steroids. Your last one that I didn't talk about is Xolair. It's a monoclonal antibody. We give it at the cancer center. It's something that we utilize. It does help patients, but I can't imagine them asking any questions about it. It's a pretty small subset that get that. So, okay. Let's talk a little bit about cardiovascular meds. Okay. So I know I talked in the last one a lot about like strokes and things like that. MIs, we talked about those. I believe we talked about congestive heart failure. That's some things that we do. I don't know if I talked about heparin on the last one. I guess we can talk about that for a little bit. Heparin is utilized in the patient population that has had a heart attack. That's pretty standard. We were taken to the cath lab. We would start them on heparin. It's also utilized for patients that have had a blood clot or have atrial fibrillation. Obviously, your monitoring parameter for heparin would be bleeding, so you would monitor the H&H. That'd be important. Additionally, you would be monitoring the APTT, which pharmacy monitors here. And again, 1.5 to 2.5 times the normal value is what's on the literature. However, we have a goal here of 62 to 100, and that's what we utilize. There is a complication you can run into with heparin regarding the platelet count, and that would be heparin-induced thrombocytopenia. Again, pharmacy is responsible for monitoring the platelet count, and we're pretty aggressive with that. So again, it is heparin-induced thrombocytopenia is an issue, but pharmacy basically takes care of that. The antidote for heparin is protamine, just so we can make sure we're complete on that. Let's talk a little bit about oral anticoagulants. Warfarin is your old school one. Also, dabigatran, rivaroxaban, and apixaban. I think I covered these in the last talk. Warfarin is really dying out. You don't see a lot of prescriptions for it anymore. The dabigatran is falling out of favor because of its safety profile. The workhorse agents that you have nowadays are the Xarelto and the Eliquis. And again, those are very similar to heparin, so that would be the population that has had the blood clots, the population that has atrial fibrillation, the population that has other issues that we talked about previously. Your book says you need to avoid green leafy vegetables high in vitamin K here. But again, if you're on Xarelto, you don't need to worry about that. If you're on Eliquis, you don't need to worry about that. That's more for Coumadin. Again, your reversal agent for Coumadin is vitamin K. The reversal agent for dabigatran is actually Praxbind. That's a monoclonal antibody. At least I think it is. And Xarelto and Eliquis, it's typically going to be Kcentra. But the other option would be something like Andexanet Alpha. Andexanet Alpha is fantastically expensive and is not on formulary at Trinity Health. Okay, we talked already about the alteplase. I'm not going to get into that. We talked a little bit about antiplatelet meds. I'm not going to get into that. Let's talk a little bit about blood pressure meds. So again, we have like diuretics, okay? Loop diuretics would be like Lasix. That's pretty aggressive therapy. And then you also have thiazides. That's going to be your starting point for blood pressure in most situations. So yeah, again, if you're diagnosed with hypertension and you don't have any other issues, you're typically going to start you on a thiazide diuretic. Lasix is reserved more for your congestive heart failure population. Let's see. We talked about ACE inhibitors. Let's see. Sorry, just looking for some more stuff to go over with you guys. Okay, let's go over some neurological questions. Levodopa is prescribed for a client with Parkinson's disease. The nurse monitors the client for side effects and adverse effects of the medication. Which findings indicate the client is experiencing adverse effects? Pruritus, tachycardia, hypertension, impaired voluntary movements. So again, the carbidopa, levodopa can cause dyskinesia. That's just one of the side effects. So impaired voluntary movements, that's going to be your big one right there. The home healthcare nurse visits a client who is taking phenytoin to control seizures. During the assessment, the nurse notes the client is taking birth control pills. Which information should the nurse include in the teaching plan? Well, the Dilantin enhances the rate of estrogen metabolism, which decreases the effectiveness of some birth control pills, okay? So when they're on both medications, you're pretty much going to want to make sure that they have some sort of backup plan in place because they can't just stop their anti-seizure medication. Nurse is caring for a client in the emergency department who has been diagnosed with Bell's palsy. The client has been taking acetaminophen and acetaminophen overdose is suspected. Which antidote should the nurse prepare for administration if prescribed? Pentostatin, no. Anafrin, no. Flublazine, no. Acetylcysteine, yes. The acetylcysteine is the reversal agent for Tylenol overdose. That's just one of them you're going to have to remember. Meperidine has been prescribed for a patient to treat pain. Which side effects should the nurse monitor for? Diarrhea, tremors, drowsiness, hypotension, urinary frequency, or increased respiratory rate. So basically the meperidine is an opiate. Side effects include respiratory depression, so increased respiratory rate would not be one. Urinary retention, again, urinary frequency would not be the answer. Nausea, vomiting, and tremors. Meperidine is not commonly prescribed anymore, but may be used for acute pain in the as a preoperative medication. Again, I've only ever verified meperidine on a patient that was in the cooling protocol and like for rescue for chemo. That's it. So because of that, we're very, very careful with prescribing it, and that's because it lowers the seizure threshold. So your answers to this question will be 2, 3, and 4. So that would be, we monitor for tremors, right? Just like we talked about. We monitor for drowsiness, and we monitor for hypotension. Again, standard opiate monitoring. A client is taking the prescribed dose of phenytoin to control seizures. Results of the phenytoin blood level study reveal a level of 35. Which laboratory would be expected as a result of this? Which finding will be expected as a result of this laboratory? Hypotension, tachycardia, slurred speech, no abnormal findings. So basically, as the Dilantin level goes up, it can cause nystagmus, which is a big one, but above 30, ataxia and slurred speech occur. So again, we have slurred speech as an option. That is the answer. A client arrives at the emergency department complaining of back spasms. The client states, I have been taking 2 to 3 aspirin every 4 hours for the last week, and it hasn't helped my back. Since acetylsalicylic acid intoxication is suspected, the nurse should assess the client for which of the following: tinnitus, diarrhea, constipation, photosensitivity. I just don't remember off the top of my head, so we're going to take a look. Mild intoxication with acetylsalicylic acid is called salicylism and experienced commonly with a daily dosage higher than 4 grams. Tinnitus is the most frequent effect noted with intoxication. So again, tinnitus is an option for us. That's what we would use. A client with trigeminal neuralgia is being treated with carbamazepine 400 milligrams oral daily. Which value indicates a client experiencing an adverse effect of the medication? Sodium level 140, uric acid level 4, white blood cell count 3, BUN 10. Let's see. It's the white blood cell count of 3 because the carbamazepine can affect the blood lines and cause aplastic anemia. So again, in that situation, you're going to want to remember carbamazepine. We want to monitor the blood count. Let's see. Nurse is caring for a patient with chronic back pain. Codeine has been prescribed. Specific to this medication, which intervention should the nurse include the plan while the client is taking this medication? Monitor radial pulse, monitor bowel activity, monitor apical heart rate, monitor peripheral pulses. So if you think about it for a second, codeine is what kind of medication? Codeine is a pain medication, and it's also an opiate. And because it's an opiate, it can cause constipation, okay? So again, opiates would be things like Norco, things like morphine, things like codeine, like we talked about, meperidine. All of those things can cause constipation. All of those things, you want to monitor that bowel activity. Okay, the nurse is given a medication instruction to a client receiving phenytoin. Which statement indicates the client has an adequate understanding of the instructions? Alcohol is not contraindicated while taking this medication. Good oral hygiene is needed, including brushing and flossing. Medication may be self-adjusted depending upon side effects. The morning dose of the medication should be taken before a serum medication level is drawn. So for this one, we're looking at number 2, okay? Good oral hygiene is needed when you're on Dilantin. Again, you want to keep the blood levels up. I'm sorry. Again, we're going to tell them to not stop the medication abruptly, and we want to tell them to avoid alcohol. A client with myasthenia gravis becomes increasingly weaker. The primary healthcare provider prepares to identify whether the client is reacting to an overdose of a medication, cholinergic crisis, or an increasing severity of the disease, myasthenia gravis. Which an injection of polonium is administered? Which finding would indicate the client is in cholinergic crisis? I'm not going to lie to you guys, I don't know a whole lot about myasthenia gravis, but we're going to go ahead and look at the answer together. The implodium injection makes the client in cholinergic crisis temporarily worse. An improvement in the weakness indicates myasthenia crisis. Muscle spasms are not associated with the test. So again, this implodium injection, a temporary worsening of the condition, that's what we're getting at there. So the last question is 734. A client with trigeminal neuralgia tells the nurse acetaminophen is taken daily for relief of generalized discomfort. Which laboratory value would indicate toxicity associated with this medication? Sodium of 140, nope. Platelet count of 400,000, nope. Prothrombin time of 12 seconds, a direct bilirubin level of 2. So it causes, the acetaminophen toxicity causes liver issues. So I would say 3 or 4, but I think a PT of 12 is normal, and I believe the bilirubin of 2 is not normal, so let's see what they say. Yes, so the bilirubin of 2 is not normal, so it's number 4. In adults, overdoses of acetaminophen cause liver damage. The correct option is an indicator of liver function and only option that indicates abnormal laboratory value. So like I said, the PT of 12 is okay, but the bilirubin of 2 is not okay. Your typical is going to be like 0.4, 0.5, somewhere in that area. I hope this was helpful for you guys. And if you need anything else, I'm around, and you can certainly ask, and we can kind of go from there. Thank you.